So welcome everybody. This is our next webinar in the Hydrocephalus series, and this is part one of a two-part webinar on normal pressure hydrocephalus. So we're not going to cover everything today, but certain topics from the background to the disease, how we recognize it on imaging, and the preoperative workup that is typically done. And I'll introduce the panel, or at least we'll introduce ourselves. I'm Lawrence Watkins. I'm a neurosurgeon at the National Hospital for Neurology and Neurosurgery in London. And my fellow panel members are?
I am Giorgio Palandri. I am consultant neurosurgeon here in Bologna, Italy.
Hello everyone. I am Mats Tullberg from Sweden. I'm a professor of neurology and a senior consultant in neurology at the Sahlgrenska Hospital, a university hospital in Gothenburg, Sweden.
So a few other points before we start. If you want to ask the panel some questions, at the bottom of your Zoom screen, there's Q&A. So use the Q&A facility for questions. The chat panel we probably won't see. So use Q&A rather than chat, unless you want to just chat between yourselves, of course, with other members of your team. And the other thing is that although this webinar is aimed at professionals, health professionals, neurosurgeons, neurologists, neuroscientists, I'm aware that there is also some participants who are patients or their families. And so I would just, as we always do, make sure you know that this is not individual health advice we're giving. We're talking about this as an educational exercise, and you must always make sure that if you think you have one of these conditions that we're talking about, that you discuss it with a licensed health professional. Okay, that being said, I'm going to start the first part of the webinar, which is about what the condition is. I'll try and share my screen and start the Okay. So this is about normal pressure hydrocephalus. As I said, not comprehensive everything to do with hydrocephalus, but part one of a two-parter. That's the conflicts of interests. And what is normal pressure hydrocephalus? It's really Hakim's triad, which the primary feature of it is a disturbance of gait and balance, which is by far the most common thing that you will see in a patient with this condition. But to a lesser extent, there is also an element of cognitive decline and urinary urgency. And as the picture on the right shows, large ventricles. So that's really the syndrome that we're talking about. And this was first described as a syndrome by Solomon Hakim back in the 60s and reported at that time. So we've known about it for a long time, 60 years now. And if you look back in history, even earlier than that, there was a description back in 1935 by Penfield, one of the early neurosurgeons, saying that he recognized that you could have enlargement of the CSF spaces, the ventricle, with normal pressure. And so he'd recognized this phenomenon, he just didn't give it the name of the syndrome. So for those of you who work in clinical scenarios already will have seen this sort of thing, but this is a good example of the initial gait. So a patient very unsteady, requiring support of people around her and taking very small steps, particularly difficulty on turning. And this is the same patient after she's had a shunt inserted. So now, instead of two doctors helping her, she's just got her husband. It's a little bit unsteady, but much better. And this next one is, of course, a few months after recovery. Of course, not everybody does that brilliantly well, but that shows at least the potential of what we're talking about it, and why anybody who works in this field always is quite excited by dealing with normal pressure hydrocephalus, because we see the potential. So, having recognized that there is a potential for improving people, how common a problem is this? Well, there are some studies that have been done mainly in Japan and Scandinavia. The Japanese study, and most of them come up with a prevalence in the population, if you look at a particular geographic area and then screen all of your over 65s, of somewhere between 0.3 and 3% of the population have it. So it's not rare, it's a fairly common condition. And the other thing is this on the right from shows that there is an increasing prevalence with age. So in the over 70s, 70 to 80-year-olds, it's about 0.2%. But once you get to 80 plus, it's more like 6%. So much more common the older you get. And in that regard, it's worth recognizing that the older part of our population is the most rapidly increasing segment. So these statistics are from the UK Office of National Statistics, looking at the population structure back in 2009 and what it's projected to be in 2033. So this is at each age, in the central column is the age, and then each of these little steps is the number of people at that age. And you can see that the difference between the dark blue or the dark pink in 2009 and what is projected in 2033, which is the light color. The one segment of the age groups that's increasing rapidly are the people who are over 65. And of course, these statistics are pretty solid, because these are not new people that are arriving age 70. They already exist. We know they're in the population. It's just at the moment they're 13 years younger. So this is almost certainly going to happen, that we're going to get increasing numbers of people over 65, and particularly in these upper echelons, about twice as many over 80s as we're used to. So a common disease, it's treatable by a cerebrospinal fluid shunt. And at the moment, it's currently under-recognized and under-treated. So the next thing, if you say, right, well, this looks as if it's very exciting, it's a common condition which we can treat. The next problem that most doctors will think of is, well, is the treatment worse than the disease? Are we causing a lot of risk to these patients by operating on them? Do they require lots of further operations once they've had their first shunt? And this is data from the UK shunt registry. All of the shunts in the UK go into a shunt registry. So there are tens of thousands of data points in this database now. And this is a number of patients who are being operated on and how often they get reoperated on. And you can see the younger patients up here, pediatric group, are much more likely to have a reoperation than the elderly, the over 70s. And so there's a lower reoperation rate in the elderly patients. And this is a systematic review that Ahmed Toma did some time ago, looking at how this has changed over time. So back, you remember it was first described in the 60s. In the early days, in the 70s, for example, there were reports of the mortality rate being 9.5%. and hence a lot of resistance to doing operations like this. But over time, this has improved. And really, if you look at the data from 2006 to present day, it's more like 0.2%, so a much lower complication rate than was described in the early years. And of patients who do well of having a shunt, again, in the early 70s, it was not really a very good response rate, less than 50%. Now, about 80% of patients are said to improve. So things are improving and have improved. So if you read old papers, you get a completely different impression than if you read recent papers. This is another paper making the same point, looking at the over 80s, which a lot of people would assume are too old to operate on, but in fact, they're not. As long as their general health is good, then their chances of improving is increasing over time. up to getting up to above 80 or 90%, and the complication rate is going downwards over time, so that now the complication rate is comparable with other forms of surgery. And then, although a lot of measures are looking at walking speed and measures of walking ability, if you just look at the overall quality of life, there are studies that have been done on that as well. Are patients feeling better and performing better in their lives? And the answer is yes. Putting a shunt into these patients generally improves their quality of life. And what about the economics? Isn't operating on people expensive? Well, this study is a large one that was done in Japan, and they did do an economic analysis and looking at the price of shunts and the price of looking after people who have impaired mobility. And if you do the modeling, then at about 18 months or just under, a shunt pays for itself in the improved quality of life and lower care costs of the population. So even on economic terms, it seems to make sense. Now, the other thing is this something that we can just wait and see? Well, you can, that's always an option, of course, but studies such as this one, done by in Sweden, was looking at patients who had inevitably, due to logistical problems, been delayed in getting their operation. So the on an NPH score of how good they were, the green ones are the ones who were operated on more or less straight away. So, and they improved significantly having their shunt between this column and that column. Another group who weren't able to get their shunt straight away and were delayed by more than 3 months had declined over that time. And although they did still improve with the shunt, so it was still worthwhile doing, they never got quite as good as the ones who were operated on straight away. And I fear that we may see this all over Europe due to the delays that have been introduced by the COVID pandemic, which has delayed a lot of neurosurgical operations. And so we may have people who will have come to some harm by the delays involved. So this seems like an interesting condition. So how can we understand it? It's first look, it seems nonsensical. How can you have hydrocephalus with normal pressure? Does that make sense? Well, actually, it's not a disease of pressure. It's a disease of pulsatility dynamics. And it's most common in the elderly because it's partly to do with arterial stiffness and partly to do with decreased efficiency of CSF movement. So this is the sort of scan that we're used to seeing, sagittal plane through the brain on an MRI. But what we're learning is that this is only part of the truth. The real truth is more like this. And if you have dynamic MRIs, which are relatively recent techniques, the whole brain is moving with pulsatility of the blood flow into it. So Walter Dandy back in 1919 was looking at hydrocephalus in dogs, and this particular dog had blockage of the foramen and Monroe on this side, and the ventricle expanded on that side. So he thought, well, that makes entirely good sense. The CSF is being produced by the choroid plexus. If there's a blockage, then you get a buildup, very much like a dam. If you put a dam across a river, you get a buildup of fluid upstream. That made sense, and that is still true in some circumstances. Sometimes it is that simple. But Behring's studies in the 1950s and 60s was looking at pulsatility. So he was looking at pulsatility where the choroid plexus was present on one side, in this case, the left ventricle, and not on the other side. And the pulsatility is greater in the side that has the choroid plexus. Now, what do you think would happen in such a patient if you had no blockage at all, but a change in the pulsatility? What you still get is expansion of the ventricle that still has the choroid plexus in it. And remember, there is no obstruction at all of any of the pathways. So it's not like a dam across a river. It's more like the movement of the sea. There are tides, there are waves, there's interactions with surfaces. And you really have to understand all of those things in order to really understand hydrocephalus. So we have a solid skull and a pulsatile heart. And so as the brain expands with the pulse wave of blood entering it, CSF moves out of the way and down into the spine. And as Per Eide has shown, when you put in a ventricular peritoneal shunt, not only are you changing the pressure, but also you dramatically reduce the pulse amplitude. So the pulsatility is being modified by putting in a shunt and being made lower. So the other thing that we may be doing is changing lymphatic flow and the clearance of metabolites from the tissue of the brain. And the CSF flows in the perivascular spaces through the brain tissue and clears out metabolites. And this is a picture of a mouse brain, and the CSF has been dyed green. So at the moment in an awake mouse, you can't see any green at all, but as the mouse goes to sleep, this is what happens. The CSF goes down the perivascular spaces and out into the tissue. And this happens during sleep. And as we're learning more about this in humans as well, this seems to be one of the major functions of sleep, is clearance of metabolites via this pathway. So thanks for listening to that brief introduction. I'd like to thank my team, especially Linda Tantona, one of our research students, who gave some of those slides that I used. Thanks very much.
Thank you very much, Lawrence, for your excellent talk. It is not easy to tell the audience everything about INPH in such short of time, but that was a good overview. We have some questions coming in, and I can just repeat what you said, Lawrence. Please post your questions on the Q&A function at the bottom of your screen. So I will start reading out a question here from one of the persons who have listened. Is having an NPH shunt operation more risking during the current COVID-19 conditions? Should a patient wait to get vaccinated if possible? What would you suggest?
At the moment, it is definitely true that there is an increased risk due to COVID, because putting in a shunt involves having a general anesthetic, and having a general anesthetic, if you happen to have COVID at the time, is a very high risk. In some reports, up to 20% mortality amongst patients having general anesthetic while infected. So we can reduce the risk by screening people who are coming in for operations. And so we haven't stopped operating entirely, but we try and minimize that risk, but you can't eliminate it entirely. And yes, if a patient is waiting for a shunt, you have to remember that the green and the red columns I was showing you just now, there is a price to be paid for delay as well. And so you have to get a balance depending on your local circumstances. How prevalent is COVID in where you're working at the moment? What age is the patient? Have they got any comorbidities that are going to increase their risk? And you judge best whether delay is a greater risk or coming in via a low-risk pathway, because COVID is being managed in terms of risk by pre-screening everybody coming into particular pathways in the hospital. So, but it is an increased risk that we have to take into account.
Lawrence, you told us that INPH is definitely under-recognized and under-treated. Can you please clarify this concept?
Well, in the prevalence studies that have been done by looking at a particular geographical area and then screening the elderly population within that area, the prevalence that we're coming up with is around, as we said, about 0.3, or probably more likely around 3% of the over 70s. And if we project that for UK, for example, we know pretty much how many people we should be picking up with normal pressure hydrocephalus. And we know from our UK shunt registry how many we are actually operating on. And at the moment, that figure is about 1/10. So we are not seeing a lot of the population that if we screened everybody over 65 in the UK, we would pick up a lot more cases. But of course, at the moment, we can't screen everybody in the UK. at least with current technology. So yes, it's under-recognized, and we're very dependent on our colleagues in other specialties, neurology, care of the elderly. Radiology is actually a very influential subspecialty in finding these people and referring them appropriately, or at least bringing up the possible diagnosis. And so, yes, at the moment, very much under-recognized. And of course, if they're not spotted in the first place, they can't be treated.
Lawrence, there are some questions coming in about the pulsatility and versus pressure. Could you elaborate a little bit more? What is the difference? I read out here. So it is pulsatility and not pressure that is the pathophysiological mechanism. Please explain this further.
Well, we know that pulsatility is increased in these patients, and Per Eider, who's one, I showed some of his work in one of the slides towards the end of my talk, has shown that pulsatility can be used as a diagnostic criteria because all of the patients have increased pulsatility. And the theory is that as your arteries age, then the pulse wave in a young person is damped from the heart to the brain by the expansiveness of their soft young arteries. But as you get older, the arteries get harder, and so the pulse wave from the heart to the brain is much harsher. It is a higher peak and steeper. So that pulsatility is one part of the equation. And the thing that normally damps the pressure inside the cranial cavity is the movement of CSF out into the spinal canal. So that's a way of volume moving out of the way and therefore damping the pressure wave. But if anything is impairing that movement, then that mechanism doesn't work so well. And so you get an even higher excursion in the intracranial pressure with each pulse beat. And that seems to be part of what is putting stress on the tissue and causing the syndrome. And when you're putting in a shunt, yes, you are taking fluid away, but you have to look at the curve of pulsatility against pressure. And if the patient is on a steep part of the curve, then for every little bit of pressure increase in overall ICP, their pulse amplitude changes quite dramatically. And so in these patients, by reducing their pressure only a little, you're moving them to a different part of their compliance curve. And so this is something that Marek Chosnica, who is also asking questions, and has pointed out that if you understand the compliance curve, this is part of it. And so that is one theory.
Okay, I think we should move on, and we can come back to general questions, and we can pick from questions you have posted at the end of the 3 talks, I would suggest. So, Giorgio, please continue with your talk on radiology.
Okay, thank you, Mats. Good evening to all of you, and thank you very much to the ANS and to Mansour Fourougi for encouraging and supporting this webinar. Thank you also to Sanya and Roji, who developed this beautiful CSF task logo. Today we are dealing with radiology in IMPH, and I will try to answer the question of what role does neuroradiology play in IMPH. I must warn you that I am no neuroradiologist. I'm a neurosurgeon. So in some way, I think that you can relax. I will not, because I'm not able to descend into technicalities. We will just analyze the problem from a neurosurgeon's perspective. And I will try to make a brief and necessarily not exhaustive review of the literature on radiological markers of IMPH we have been using here in Bologna from 2015 when the ProHydro team for IMPH was created. We should say that radiology constitutes one of the 3 pillars of the diagnosis, combined with clinical and supplemental prognostic tests. If we go through the 2005 international guidelines, we see that it is stated that in order to establish the diagnosis of IMPH, it is required to have a convergent evidence from the clinical history, physical examination, and brain imaging. And the documentation of a ventricular enlargement, the so-called Evans index 0.3 or equivalent, by brain imaging is necessary but not sufficient in itself to establish a diagnosis of IMPH. The diagnosis of a probable IMPH requires a ventricular enlargement not entirely attributable to cerebral atrophy, no macroscopic obstruction to CSF flow, and at least one of the following supportive features: the enlargement of the temporal horns of the lateral ventricles, a callosal angle of 40 degrees or more, the evidence of altered brain water content, and an aqueductal or foreventricular fall void on MRI. This was probably clear in 2005, but I must admit that they sound nowadays a little bit confusing in 2020, and I'm happy there's a new group who is actually working on new guidelines, and I think that we definitely need them. If we go through the Japanese guidelines published in 2012, we can see that the Japanese criteria emphasize the finding of disproportionately enlarged subarachnoid space hydrocephalus, requiring it for the diagnosis of probable IMPH if no CSF drainage test is performed. However, I think that on one point we must all agree that the sooner the diagnosis is made, and the better it is for the patient, for the caregiver, for the physicians involved in the diagnosis and the treatment. In this presentation, I will touch briefly 3 radiological parameters useful for the diagnosis of IMPH: the Evans index, the DASH, and the callosal angle. Is nowadays the Evans index adequate to describe ventriculomegaly? Probably not. We will need in the future others and better radiological markers, such as, for example, ventricular volume or area measured routinely in a daily practice and not only in experimental studies. This is a recent personal case. You can see here that the Evans index is below 0.3, but the patient has an Achim triad as a positive response to the TAP test, and he will be definitely offered a shunt. But how much important in the elderly is the finding of a ventricular enlargement? In this study from Baroncini, they divided 90 patients in 3 groups: patient with ventriculomegaly without clinical signs, patient with ventriculomegaly who responded positively to the shunt, and patients with ventriculomegaly who did not respond to the shunt. And they noted that the Evans index was higher in responders, and even a greater difference was observed for ventricular area and volume values. Here you can see how Evans index is larger in responders than in control, and it is also true as it regards the ventricular area, the ventricular volume, the callosal angle, and the stroke volume of the flow void through the aqueduct and upper cervical spine measured with the phase contrast MRI. Which is the importance of ventriculomegaly as an incidental finding? In this beautiful Japanese prospective study, a series of asymptomatic patients was followed through the years, and it was able to demonstrate that the progression rate from asymptomatic ventriculomegaly to IMPH was nearly 20% per year, and the Japanese grading scale was able to predict the progression from asymptomatic to symptomatic patients. Which is the prevalence of ventriculomegaly and DASH in the population? Is it associated with symptoms? In this study published by Chihiro Akiba in 2020, they studied two cohorts of patients, the memory clinic-based cohort, the community-based cohort, and you can see here that in the memory clinic-based cohort, the prevalence of DASH was 1.1%. The clinical triad was significantly more frequent in subjects with DASH, where it was present in 50% of the cases, but if only ventriculomegaly was present, the percentage descends to 12%. If we look at the community-based cohort, we can see that the prevalence of DASH is very similar, 1%, and also the clinical triad was significantly more common in subjects with DASH and ventriculomegaly. Is ventriculomegaly sufficient to diagnose IMPH? Of course not. We already know, we have already said it. Ventriculomegaly can be associated with many other neurological diseases, and it enters in differential diagnosis, for example, with Alzheimer's disease and progressive supranuclear palsy. Coming back to the second of our radiological markers, we must cite this prospective multicenter study, a part of the Japanese Symphony study, in which 26 centers enrolled 100 patients with an Evans index above 0.3 and the DASH. The results were extremely promising, with an overall response to shunt almost of 90% and an improvement of almost 70% at modified ranking scale. This finding was later confirmed by Narita. They enrolled 60 patients. The follow-up was 1 year. They took into account several parameters, the Evans index, the high convexity tightness, Sylvian-Fisher dilatation, the callosal angle, focally enlarged sulci, bumps on the lateral ventricle of the roof, and deep white matter hyperintensities. And at multiple linear regression analysis, high convexity tightness alone was able to predict clinical improvement. Previously, in 2014, Viramar had already published a similar study in which the importance of DASH was underlined. However, we must say that the enrollment criteria and the statistical analysis performed are different in these two studies, even though they look quite similar. Are all DASH equal? Of course not. Even in this occasion, the answer is no, but we do not have time right now to describe this interesting study in detail. We will just use the words of the authors at conclusion that MRI-based DASH scoring is useful for the prediction of neurological improvement and prognosis after surgery for IMPH. But is it as easy as it sounds? It is a no, again. In this study published by Agerskov in 2019, 168 patients were retrospectively reviewed, and despite a follow-up, 68% of them were improved, only 26% of them had the DASH. Similar findings are reported by Claudia Craven, and also Dr. Ahmed analyzed retrospectively Johns Hopkins series, and despite they had more than 80% of the patients improved, only 37% of them were DASH positive. Another important marker to achieve a radiological diagnosis is indeed the callosal angle. It is known to permit a good differentiation with Alzheimer's disease patients. It has positive predictive values on shunt outcome, and it is actually one of the parameters of the RAD scale. We will come back to that later. Here are two papers from Viramar and Granke, in which the importance of the callosal angle is underlined. However, the relationship with the pre-op clinical symptoms of the callosal angle is still debated. It is still unclear. This is why we decided to analyze the anterior callosal angle. It is very similar to callosal angle, but it is calculated from the level of the anterior commissure here instead of the posterior commissure. So it has the advantage to project in more anteriorly located brain areas, namely the frontal lobe and mid-cingulate cortex, which are more clearly involved in the typical gait apraxia, in the cognitive profile of IMPH patients, and in micturition control. We were able to demonstrate the ACA can distinguish IMPH from healthy controls and AD patients. ACA had also a positive correlation with the Tinetti scale, both the global and the gait score. And it is able to differentiate risk fall categories, thus potentially influencing IMPH patients' management and care. It also correlates with Tinetti score as it regards the postoperative outcome and risk of fall. A narrower pre-op ACA is associated to better outcome. The narrower, we could say, the narrower the ACA, the better performance after the surgery. Last but not least, I want to stress the importance of using validated and standardized scale. I want to mention again the RAD scale. Perin, Kokum, and the UMIA group have already published 2 papers. They stated that IMPH RAD scale could work as a diagnostic screening tool to detect IMPH, but whether the scale also can be used to predict shunt outcomes needs further studies. But I strongly suspect that we will soon hear again from them. I thank you very much on behalf of all ProHydro team here in Bologna. Thank you again.
Thank you very much, Giorgio. Interesting Odysseys through the radiological world of Hydrocephalus. I'm looking through the questions here, and I'm happy to see that you are posting questions along the way here. What would you say should be included in an NPH protocol for MRI? Could you start by telling the audience a little bit about that? And is CT as good as MRI, or should we leave CT out of this?
Well, I think that looking toward the future, I think that we must leave behind CT scan and look forward to the MRI. This has several reasons, but mainly that, of course, the MRI can permit us to study much better the brain parenchyma. And regarding what I consider very useful in the routine MRI study, I think that the 3D slice with thin slices and the possibility of the reconstruction, this kind of exam gives us the possibility, for example, to replicate scales and to replicate studies. So we should go back and retrospectively review our exams, but of course only if we have some kind of examination. I mean, the 3D slices are really very, very useful. For example, if you want to go back and look at the callosal angle or the anterior callosal angle.
What about the stroke volume through the aqueduct? Do you use it for decision making? That's another question.
No, I'm sorry. Right now we have more than 150 patients who had a 3 Tesla MRI before and after the operation. We are measuring the stroke volume. But to date, I have no data. In the IMPH guidelines in 2005, it was not a significant marker for IMPH, but techniques are really different by now. So I think that it will be a matter for future studies.
I pick one last question and leave the word to you, Lawrence, which I find interesting here. Where should we measure the callosal angle exactly? Because that makes a lot of difference depending on how you align the coronal sequence and at what point, at which slice you perform the measurement. Could you just elaborate a little bit on that?
Yes, that's a very good point, a very good question. Of course, it must be a standardized measure. You draw the line between the anterior and the posterior commissure, and the orthogonal line to the posterior commissure. There, on the coronal view, you measure the callosal angle.
Very good. Lawrence, do you have any questions to add to this?
You must unmute your microphone.
More of a comment really, Giorgio. I've also been finding MRI of the spine is quite useful, maybe because we're doing a lot of lumbar drainage as part of our workup, but also it's a useful screening tool to rule out other mimicking conditions. And so, yes, if you are lucky enough to be in a center with easy access to MRI, it's worth considering MRI of the spine in addition to MRI of the head.
Yeah, I do completely agree with you.
A good point. I will touch a little bit on that in my talk.
Okay. Shall we continue with Matt's talk now?
Yes, let's do that. And we can, as I said, come back to more questions. There are some general questions that we have not picked yet, but we could perhaps come back to them.
Yeah.
So, let's see here. Okay, hello everyone. I will move to my first slide. Sorry about that. I'm very happy to present some facts about the clinical workup, and I also want to thank the EANS. And I'm very happy to be here and glad to share my experience on INPH. I come from Gothenburg, Sweden, and I have no conflicts of interest to declare. So I will try to find most important regarding the clinical workup, because that is very essential. I and Giorgio has touched upon some very important parts here and facts that we must relate to when going to the workup of patients. And I want to start by a short background here stating some things. INPH is currently underdiagnosed and undertreated. We don't treat the number of patients that a lot of studies have told us are out there. We must consider that, I think. Another fact is that large studies, for instance, the European multi-center study on INPH and the Symphony study, which Giorgio mentioned, they have shown that patients diagnosed and treated based on clinical and MRI criteria alone show good improvement rates after 12 months. And these results match improvement rates reported in most studies using an additional test for selection of shunt candidates. I will come back to that a little later when I touch on the supplementary tests that we usually use. I am a neurologist and I work every day in our Hydrocephalus center looking at patients. And the third statement here is also important, I think. These patients that we suspect having INPH, they are elderly and they may suffer from other neurodegenerative disorders or comorbidities influencing prognosis and post-operative outcome. And we need to take that into account. And lastly, patients with INPH and vascular white matter changes improve after shunt surgery, as do patients with signs of cortical atrophy, which makes it a little bit more complicated than just looking for DESH. Okay, so in my view, when we perform workup of patients with suspicion of INPH, we should start by doing the clinical assessment and hereby identify the clinical syndrome of INPH, which I think is really a syndrome, a separate syndrome. It's not just something that we diagnose after ruling out other disorders explaining symptoms. I have worked with these patients for almost 30 years now, and according to neurologists involved in this, we think there is a special clinical syndrome. We don't have time to go into that in much detail, but I will touch a little bit on that. It contains of gait and balance disturbance, which can be assessed for quality. It contains the cognitive and mental dysfunction, and it contains the urinary urgency or incontinence. So that is part one for the first step. Also, we need to assess signs of other disorders or comorbidities, because that can explain the clinical picture, or it can be a coexisting disorder with impact on prognosis and outcome. And some of the most important comorbidities are listed below here. Parkinson's disease, atypical Parkinsonian syndromes, for instance, progressive supranuclear palsy, which can act quite similar to INPH in my experience. Alzheimer's disease or MCI with Alzheimer profile, and also other dementias. So when we look at the cognitive profile, we need to take into account if patients show signs of such disorders. We have cervical spinal disorders like myelopathy or lumbar spinal canal stenosis, polyneuropathy, or other musculoskeletal conditions that could give patients similar symptoms. Of course, cerebrovascular disease, including subcortical small vessel disease, is often prominent in these patients. I will come back to that soon. And lastly, we have conditions causing urinary or micturition disturbance, other neurological or non-neurological disorders. And here we can use specific laboratory investigations directed at specific comorbidities. For instance, CSF biomarkers for Alzheimer's disease, which is quite stable as a method now. We have other methods that you can see. I have 2 publications you can look at if you want to dig further into the clinical syndrome of IMPH. If we just look a little closer to the differential diagnosis of comorbidities, they come here again. For Parkinson's disease, it's mostly to look at clinical signs, the typical triad. We also usually give the medication and see if there is any effect. And usually you have to wait for up to 3 months, which can pose as a problem because you don't want to wait too long for shunting. The atypical Parkinsonian syndromes, especially PSP, are more usually a larger problem in the clinics because those patients can show similar signs. But we can look for typical clinical signs like vertical gaze paresis. We can also use MRI or DAT scan to get deeper into that differential diagnostics. For Alzheimer's disease or mild cognitive impairment, the neuropsychological test profile is essential, I would say. Also, the history is usually of early and dominating memory decline and later development of gait disturbance. And the CSF biomarkers, the A-beta 42 and the ratio 42-40, which is reduced, and also phospho-tau, they are quite sensitive for that diagnosis. There are also other dementias. Again, the cognitive profile and the history is important. For the other myelopathy or spinal canal stenosis, we have to look for the clinical signs, and again, spinal MRI is quite useful. So if you have a suspicion of any of those disorders, you should probably add a spinal MRI. So for the subcortical small vessel disease, when I started working with INPH patients, we were more careful and usually were reluctant to shunt if there were signs of extensive small vessel disease. Several studies have shown that these patients show a similar improvement as those who have no such signs or much less. So today we are not so afraid of including such patients. They can have a more pronounced clinical picture, but the improvement is similar to patients without. We must keep that in mind. So if step 1 was the clinical assessment, step 2 is the radiology, and here a dedicated MRI protocol for assessment of INPH typical changes and comorbidities is important. And I have stated some suggestions of sequences. Your radiology will probably not have any difficulties identifying the best sequences, but you should use a T1 3D volume with thin slices which you can realign for measurement of the callosal angle, for instance, FLAIR images for assessment of cerebrovascular disease, small vessel disease, coronal images, which you can get from the T1 3D volume or have separately. And it is also important to assess flow void in the aqueduct. According to my opinion, the most important use of that today is to confirm that this is a communicating hydrocephalus we are dealing with, and not, for instance, an idiopathic aqueductal stenosis. So in this workup, I have tried to identify some success factors. If possible, I think it is highly recommended to build a team to work with the patients, including neurosurgeons, neurologists, and physiotherapists, neuropsychologists, for instance. I think a meticulous assessment and quantification of clinical symptoms, both pre and post-operatively, is an essential part of it, both for the diagnostics, differential diagnostics, but also for the follow-up of patients. You must be sure that the effect is what you predicted, and if not, you need to dig further into that to see if there is anything wrong with the shunt. Another thing is the systematic use of objective measures for assessing symptoms and change after surgery, and it is advised to use some kind of scale. We use the European INPH scale, which I will show you a little bit about soon. That is one scale that is possible to use. We make decisions for surgery at a weekly clinical conference with the whole team present, which is also a strength, I think. And lastly, surgery should be performed without unnecessary delay, referring to the slide you showed, Lawrence. I will not touch more upon that. So the neurological examination can consist of these items. This is from my setting. The medical history is very important. You should have usually a relative present who can give you information. Is there a progressive decline? The order of appearance of symptoms is important. For instance, dementia with the early onset of memory deterioration, for instance. You should observe the patient's mental condition, and there are papers showing that sleepiness, impaired wakefulness is a prognostically favorable sign. Not all patients show that, but many tell us about an increased number of hours of sleep, both during night and at daytime. Also syndrome or emotional motivational blunting syndrome with apathy, loss of initiative. You should also assess the cognitive function with some tests. You could use the MMSE as a screening tool. Of course, the neuropsychologists do more of the tests. And then it is important to try to quantify and also analyze the gait disturbance, balance. Retropulsion is a sign that is common in these patients. Assess and get the history about urgency, daily need of sleep. Paratonic rigidity is a neurological sign that is often present in these patients and can add to the picture. Some measurement of the overall function, such as the modified Rankin scale. And during this investigation, look for signs of comorbidities. We perform an LP at the same time as we do the neurological examination. If you don't have a neurologist in your team, I would advise that you identify one who could work together with you and you could do these assessments together, perhaps. A physiotherapist is of great value, I think, and in most centers specialized at this, I think physiotherapist is responsible for the testing of gait and balance with more elaborate tests. The 10-meter gait test is a commonly used test. You can do other types of testing of gait. Balance is also important, and you can test balance function both with static function and dynamic function. And also functional movements such as the timed up and go test is very valuable and captures disturbance and improvement after surgery. And also an overall assessment of the gait pattern, the balance pattern, and so, which adds to the clinical picture. Here is a paper from our group from '95 describing some of the symptoms and concluding that gait is really not the only motor disturbance in these patients. They have impaired motor function in, for instance, the upper extremities too. The neuropsychologist should test the cognitive profile, and here there are a number of tests that can be used. This is a cognitive syndrome characterized as a frontal subcortical syndrome with disturbance of, for instance, executive functions. And this is a paper from our neuropsychologist Per Hellström in 2008 showing a test profile in INPH patients, measured here as a score from 0 or 20 here up to 100, which is the reference results from age-matched population. And you can see on the tests here, the black bars diagnosis and the white bars are post-operatively. And you can see that most of these scores improve after surgery, and they can also measure the symptoms that the patients show. And in our neuropsychology test battery, we use these 5 tests for assessing the INPH part of the cognitive function. We also assess, or the neuropsychologist assess, mental functions, and also look for other causes of cognitive decline with tests that can capture, for instance, Alzheimer's disease. This is an example of the INPH scale, which is constructed as giving a score, a composite score measuring gait, neuropsychology, balance, and continence domains. And a total score of 100 represents the performance of a healthy individual in about the same age without any symptoms. This is an example of a patient preoperatively with a total score of 42. It's easy to see the different parts of the symptoms. You can also compare a patient. This is the same patient preoperatively improving from 42 to a total score of 80 post-operatively. So it's a visual of the symptoms. Well, I've talked a lot about the clinical part and the MRI here, but what about the supplementary tests? There are, during the history, there has been proposed a large number of tests, and here are some of the most important types or methods on this image. I will focus on these 2 intracranial tests measuring CSF dynamic disturbance. So the most used predictive tests are these 2 types, CSF dynamic and drainage tests. ICP measurements, wave analysis, pulse amplitude measurements, measurements of compliance and elastance, measurements of resistance to CSF outflow, and aqueductal flow void could also be mentioned here. And among the drainage tests, it's the CSF tap test, which has been proposed in different ways, and also the extended lumbar drainage test, which Lawrence mentioned earlier. The short message here is that none of these tests has really proven reliable to use as a routine screening test to select candidates for shunt surgery, and these tests must be used with caution. The problem is usually that they can have an ability to identify shunt responders, but they are very poor or have a poor way of identifying patients that will improve. A lot of the patients with negative results still improve after shunting, which you will see here. If we start off with the CSF tap test, this is one study. the only one of the few, I should say, class 1 studies where in many of the publications, these tests has been used to identify or include patients for surgery. In this study, the patients were diagnosed only based on clinical symptoms and MRI. And if you look at this picture showing all the patients in blue dots here, the horizontal line is, and the red arrow shows patients with a positive TAP test. And that the vertical line with the red arrow, those are the patients who improved after shunting. So using this as a measure of positive TAP test, this is the TAP test that was published by Karsten Wickelse in the 80s. We have a quite reasonably good positive predictive value, but the negative predictive value was very low. A lot of patients improved despite having a negative TAP test, which is really a problem. In the same study, using lumbar infusion test, ROUT was also investigated. And I have here marked the two levels that were used. Either an ROUT above 12 or ROUT above 18. And again, you can see the improvement to the right here. 5 points is the minimal change that usually sets the border for improvement. So all these patients are improved. And as you can see, a lot of patients improve with ROUT below 12. If you move the bar up to 18, you capture the patients that improve, but a lot of them are with below ROUT below 18 improve. And this gives a very low negative predictive value also for the lumbar infusion tests. So the conclusion of this paper was that routinely performing a lumbar spinal infusion test and a CSF TAP test does not provide enough added value to select patients for shunting. So the conclusion should be that you should use these tests only when necessary, and if you cannot use the clinical picture and MRI as inclusion. What about the extended lumbar drainage test? This is a review article meta-analysis of the literature that was published this year, quite recently. The authors here did a literature search, and they could only identify 4 papers that were really able to answer this question: is there a predictive value with the extended lumbar drainage test? The results vary a little bit, but they were disparate. And the conclusion here was that there is little robust evidence exists to support the use of ELD in diagnostic algorithms for INPH. The sensitivity and predictive value are probably the same as for the CSF TEP test. So this could be used as an alternative to the CSF TAP test, in my opinion. There are some complications to ELD reported, meningitis and death, as you can see, and also subdural hematomas. And the disadvantage with the ELD is that you have to have the patient in a hospital bed for 3 days. So it's a little bit more cumbersome. Lastly, something about the ICP monitoring, wave analysis, and those measures. And here it's the same problem, really. The predictive value has really not been proven. You can probably pick patients that improve after shunting, but there is a high risk that you exclude patients with negative tests who still could improve. So using these methods, we exclude patients that will improve after shunting, which I think can add to the problem of not diagnosing all the patients that are out there. I think I can move a little fast through these pictures, but the European multicenter study had an objective to investigate if using only clinical and radiological criteria, what would the outcome be. And as Giorgio mentioned, almost 70% improved on the modified ranking scale, and more than 80% improved overall on the INPH scale, which is a good result. And the Symphony studies have also showed about the same outcome. So in my view, and this could of course be discussed, I think this is a flow scheme that could be suggested as a master for the clinical workup. First question is, can you identify the clinical syndrome of INPH? If the answer is no, then there is another primary diagnosis. If the answer is yes, then look at the MRI. If that is compatible with INPH, and here you should allow signs of small vessel disease and at least some atrophy, then you should move on. If you have no significant signs of comorbidity, and this could be supported by CSF biomarkers, for instance, the Alzheimer's disease biomarkers, then I think you should go on and decide for shunt surgery. This is the way that it's done in the European INPH study and also in the Symphony studies. On the other hand, if you have a difficult clinical picture, if the MRI is challenging, if you have a significant comorbidity, that probably will affect prognosis and the outcome of shunting, then you should add some kind of additional test. For instance, the CSF drainage test, like the ELD or the TAP test, or a lumbar infusion test. And if that test is positive, then you can go for shunt surgery. So I'm beginning to come to the end of this talk, and I put some take-home messages here. Careful evaluation of history and clinical symptoms should be done for a diagnosis of INPH and for assessment of comorbidities. You should use a standardized objective clinical measures and scales, such as the 10-meter gait test and the INPH scale. You should use MRI with a focus, at least for now on morphology and aqueductal flow. The LP for measurement of the opening pressure and also biomarkers for neurodegenerative disease. And if clinical symptoms and MRI are compatible with an INPH, you could go for a shunt. But in difficult cases, you should use a supplementary test such as the CSF TAP test to support decision for shunt surgery. But you should be aware of a risk of a false negative result. And then finally, you should repeat the clinical evaluation and MRI at follow-up after 3 to 6 months. Thank you very much for your attention, and I invite you all to the next meeting, Hydrocephalus 2021, which will take part here in my hometown, Gothenburg. Thank you.
Thank you very much, Mats, and congratulations. I would like to pose you one question. Speaking of supplementary test, what would you prefer? TAP test with withdrawal of 30 cc's or external lumbar drainage? What's your daily practice?
I think this varies, and in our experience and in our setting, we use the CSF TAP test. We drain 50 milliliters of CSF. That is our ambition, and it is based on the original report of the TAP test in the 80s by Karsten Wickelse. We measure some cognitive function. We use two or three tests, and we do an elaborate testing by the physiotherapist. And it is very standardized. So the patient comes to the clinic at noon, day one, perform the tests, then go back home usually. The next day we perform the TAP, the drainage at about 9 o'clock, and around 3-4 hours after the drainage we redo the tests. There is an interesting study by Virhammar in Uppsala. He measured the change continuously at several time points for 24 hours. And the problem is that some patients don't respond in 3 hours. That is a difficult part of it. So it might be that we can develop the TAP test further, but it's quite cumbersome to measure symptoms every 3 hours or so for 24 hours or even for several days. There are patients who report improvement 1 or 2 days after the tapping. So we usually add a phone call to ask the relative and the patient about their experience. If we find improvement that is not very significant, and in addition to that the patient reports that there was a huge improvement later on that was temporary, then that might get us to the point where we call it a positive TAP test. But I know that there are TAP tests draining 20 or 30 milliliters, so depends on what report you want to rely on.
Yeah, and please, can you briefly answer even to Dr. Engel's questions about the quantity of improvement you find necessary in order to establish that the response is positive, for example, to the TAP test?
It depends on what tests you use, but a gait test, 10-meter gait test is such a test where it is proposed about around 20% improvement. That is a simple rule, I would say. The problem is that you can have improvements in several aspects. You can have a different type of gait disturbance. Patients can suddenly, well, that might be difficult to capture just measuring time. So we usually do a composite evaluation, including balance, gait, 10-meter gait, that timed up and go test, if we are talking about the motor and balance tests. But 20% improvement in the gait test is rule of thumb, I would say.
Okay, thank you.
And it's important to standardize it. So you shouldn't rely on clinical examination performed 3 months earlier. You should do it the day before and then redo it the same day as you perform the drainage.
Yeah, on the TAP test, you were saying 50 mils is like the accepted target, according to Karsten's early work on it. And I would say that in practice, what you do is you have the patient continually telling you if they're developing a headache. And at that point you stop, because in theory, you may be stretching their bridging veins and about to give them a subdural. So you would probably limit it if they begin to get headache.
That's a very good point. Exactly. In my experience, few patients experience headache, but you have to be careful. Sometimes we start by doing an infusion test, and then we drain, and then we can measure the pressure. So when we get to 0, we stop draining. So that's important to be aware of that. It's, of course, you shouldn't take any risks.
Yeah. And from my viewpoint, we would say that we tend to use the extended lumbar drainage protocol, partly because it gives the patient a taster of what's possible in their case. And the effect, if they get an effect, tends to be longer lasting. So they can kind of try it out at home over the next few days and see. So then when you come to trying to make the decision with them, they have a better idea of, okay, what are the potential benefits? So that it helps with the discussion with the patient in deciding whether to go ahead or not.
That's a good point too, I think. And of course, if you have a positive TAP test and you perform shunt surgery and the patient does not improve, then you must really consider what is wrong. So it's a strength if you have that with you when going to surgery. But a problem is that if you use this, which there has, or at least has been a tendency to do, to use one of these tests as a screening method and just take on the patients that show improvement, then you're excluding a large group of patients that you could have helped. And of course, this is a very important task for future research, to identify tests that can predict the response much more accurately. And there are different ways of doing that, looking at dynamic functions, more MRI measurements. I hope that we can get either an MRI or radiological measure or CSF biomarker that can help us show which of the patients are respondents and who are not.
Yes, all of the tests that we've been talking about, and none of them are perfect. So
exactly.
We're still searching for a better way.
Yes.
I think it's an important point though, Matt, both an LP and the extended lumbar drainage test or anything else, the negative excluding people and saying you will not give them a shunt it shouldn't really be used as a basis of excluding people.
No.
Particularly, we find with the extended lumbar drainage protocol, sometimes we haven't been able to measure any improvement, but they felt better in their home environment. Their families noticed a difference. And then we would always have the discussion of saying, well, would you like to go ahead anyway? Even though we couldn't measure it, you obviously noticed it.
There, I see some interesting questions here. One question is if we consider the TAP test positive if patients show improvement only in cognition and not in gait. Well, that's a tricky question, I would say. Usually we want to see improvement in gait, but there are patients that in fact have a predominant cognitive dysfunction. And I would say that such a test result would be interpreted as a positive test in our center at least.
Same here. If we had neuropsychology, and our neuropsychologists are very good, if they said that there's a significant improvement in cognition, and usually the patient is aware of that as well, they often say, I feel brighter, or I feel much like I used to, then that in itself would be worth considering a shunt.
I think so too. And here is a question also about Parkinsonian disorder, if we have seen patients with that who have improved. Well, the answer is yes. There is a group of patients with, I think, both Parkinson's disease and INPH. If they have an undiagnosed Parkinson's disease, we usually treat them with L-DOPA for a period of time, 3 months if possible. Try to sort out which is Parkinson and which is INPH. But we have shunted a lot of patients with both disorders, and we then shunt the INPH part. So Parkinson's disease is usually not a very big problem, I would say. It's much more problematic with the atypical Parkinsonian syndromes because the prognosis is much poorer. PSP usually develops quite fast and it can erase the effect of a shunt really. So we are very careful when we see signs of progressive supranuclear palsy. Then we must have a positive TAP test and consider how far the development in the PSP has been.
Do you have a protocol for the levodopa administration of the drug in the perioperative period or not?
Do you mean around at time for surgery or before?
Yeah,
or,
at the
sorry.
time of surgery. I mean, because we had some unpleasant situation with the levodopa administration during the perioperative period, and I ask you if you have any experience about that.
To give the normal medication if possible. It's a quite short anesthesia, and they usually get up again 4 hours after surgery and do a CT. So I think most of the patients are given their standard medication, perhaps
Okay.
without one dose or something, but it should be as similar as possible, if possible.
There's a question, very interesting. What's your opinion on patients with typical radiology positive type test, but only mild symptoms? Do you recommend a follow-up surgery, whatever?
Can I start? I'm very interested in that problem. I would, if the patient says he or she suffers from the disorder, I would say go for a shunt. If we can recognize symptoms that we say we believe that they are caused by IMPH and the patient is suffering from the symptoms, and especially if we have a positive TAP test, I would say definitely yes. The problem is, and what is the rationale? Well, of course, if the patient will improve, that's very good. But there are also data from reports showing that it is not good in the long run to go with an untreated INPH. The mortality is increased, and we have shown in a study from our group that in patients who improve, the mortality is similar to the healthy population, but in patients who don't improve, high. So it's a good thing for the patients that it can affect mortality in a positive way or survival. So the problematic group is the group of patients where we cannot find symptoms really, where they suffer, but when we measure, we find normal results on these tests. What we usually do then is to follow them. If they have an MRI with DESH, for instance, AVIM, we follow them for a period of time, and we don't wait too long, usually 3 to 6 months. And in many patients, there is a development of symptoms. And then when we do the retesting, we find deterioration in the direction of hydrocephalus and INPH. And then it is usually quite easy to say, now is the time to shunt.
Yes, it is exactly the same attitude we have here in Bologna. Usually, even with patients with mild symptoms who improve at the TAP test, we propose shunt surgery. But I think that must be underlined even the importance of a multidisciplinary group, because in these doubtful, I could say, cases, it is very important the follow-up of the patient. He or she feels comforted from the fact that he or she sees lots of people around and taking care of his condition. And I think this is very, very important, because the patient feel very reassured from the presence of a multidisciplinary team.
I agree totally. Lawrence, is it time to
I think we probably ought to wrap up. Some of the remaining questions are ones that are going to be covered in part 2 of this webinar, to do with the operation itself, choice of valves, following up and outcomes and so on. So we will be covering those, but in the second talk. And I think, yes, we've overrun our projected time already. So thanks to all of our audience, and thanks to the panel for that very interesting discussion. and of, I think, a very important topic, which still has a lot of research to be done on it. And the more we get the word out to pick up suitable patients, the better. So thanks, everyone.
Thank you very much.
Thanks, everyone. It's been great. See you.
Bye for now.